Today, a lot of the slides on the differential were entities that I had gotten questions about or that people had asked me to cover. And so if you have any ideas about difficult differentials or entities that you'd like to see covered in any of these sessions, please feel free to shoot me an email about that as well. So without any further hesitation, we'll go ahead and get started. The first slide was a shade biopsy, trisected. And as we zoom in to higher power, we can see that there is a superficial perivascular infiltrate within the dermis. This is probably from trunk or proximal extremity. And right away, we can see that the epidermis is moderately hyperplastic. I think as well, your eye is kind of drawn to the stratum corneum. It's actually quite thick and certainly not characterized by a basket weave configuration. As we zoom into higher power and take a look at the epidermis and dermis, we can see that there's a rather robust inflammatory infiltrate of lymphocytes centered around somewhat dilated vessels in the papillary dermis. There's confluent parakeratosis, and if you took a look at the edge of the biopsy specimen, you can actually see, and let me get my pencil here, within the parakeratotic stratum corneum, a few collections of neutrophils. Now take a look at the stratum corneum here. You don't see much serum. So we've kind of got this dry scale. Parakeratosis, we've got a few neutrophils, but there's no serum within the stratum corneum. As expected, beneath the confluent parakeratosis, the granular layers, markedly thin to absent. There are dilated and tortuous vessels evident within the papillary dermis, some closely approximating the undersurface of thinned suprapapillary plates. There are a few suprabasilar mitotic figures. And taken together, these findings are most suggestive of plaque-like psoriasis. Now, items that you might consider in the differential here are, of course, other psoriasiform dermatitis. Lichen simplex chronicus, of course, would be characterized by somewhat more irregular epidermal hyperplasia. In that condition, the cornified layer is thickened by compact orthokeratosis rather than parakeratosis. And the papillary dermis, rather than being edematous, is thickened by coarse collagen vertical streaks. In addition, in most cases of lichen simplex chronicus, there's not much of an inflammatory infiltrate, maybe a superficial perivascular infiltrate. Obviously, LSC frequently is triggered by an inciting dermatitis, but a lot of times by the time the biopsies are done, you can see no clues as to what the inciting dermatitis was. The other item that really enters into the differential here is a chronic, subacute to chronic eczematous or spongiotic dermatitis. As most of you are probably aware, spongiotic dermatitis over time become progressively psoriasiform. They're pruritic. Patients tend to itch them, and so over time they become more irregularly hyperplastic. With a chronic eczematous dermatitis, you can get parakeratosis within the stratum corneum, but typically you see serum admixed with the parakeratosis. So rather than having dry scale, you'll have this para, serum, and frequently neutrophils. In addition, there usually is some evidence of microscopic spongiosis. So the intercellular spaces will frequently be a little widened with some serum or edema accumulating between the intercellular bridges. In addition, most eczematous dermatitis will have, or more often have, a mixed cell infiltrate. Usually you can see a few eosinophils admixed with lymphocytes as well. And then finally, one could consider the possibility of Pityriasis rosea. Pityriasis rosea especially if you biopsy the Herald patch, can show epidermal hyperplasia. But Pityriasis rosea, unlike psoriasis, tends to have more focal mounds of parakeratosis, and it lacks the neutrophils within the stratum corneum or within the epidermis that we tend to see in psoriasis. And a lot of times we will get biopsies with that clinical impression. The patients may come in and with a widespread papulosquamous eruption of recent onset. And a lot of times the question is this guttate psoriasis or is this PR? Which is why I was asked to address this differential today. So let's go ahead and move on to slide 2. Pull the slide down here. And in slide 2, we have a bisected punch biopsy, also from the trunk. Within the dermis, there is once again a superficial perivascular infiltrate. The epidermis is mildly hyperplastic. In this case, the rete are kind of elongated and thinned. But I think even at this power, you can begin to appreciate the fact that there are some alterations in the stratum corneum here. Now, one thing to note, if you take a look at the epidermis here, it's a little bit irregularly hyperplastic, but notice that in these areas, see if I get the slide to stay still, you have dermis completely surrounded by epidermis. And whenever you see that, you know that the specimen has been cut tangentially. Probably when the tissue was placed in the block, it was tilted a little. And so when you see that type of change and when you realize you've had tangential sectioning, the epidermis may look a little bit more hyperplastic than it is. Nonetheless, we do have a component of epidermal hyperplasia here. And if you take a look at the epidermis, you can also see, scoot this over here, that there's a hint of microscopic spongiosis. Unlike the case of psoriasis that we saw, there's slight widening of the intercellular spaces here. Within the overlying epidermis, there are subtle mounds. Let me see if I can erase that mark. There are subtle mounds of parakeratosis, and some of these actually contain serum. So taken together, and within the underlying dermis, there's a superficial perivascular infiltrate of lymphocytes, and in some areas, numerous extravasated red blood cells. So taken together, what we have here is a spongiotic and slightly psoriasiform dermatitis with a little bit of scale crust in the stratum corneum. And this is kind of our prototypical picture for a very focal spongiotic or eczematous dermatitis. This is actually an example of Pityriasis rosea. And in Pityriasis rosea, we frequently get mounds of parakeratosis within the stratum corneum, sometimes containing serum, usually a little bit of microscopic spongiosis within the underlying epidermis. All of this in concert with a superficial perivascular infiltrate of lymphocytes and a lot of times extravasated red blood cells. You don't see the neutrophils that we see in guttate psoriasis or in psoriasis in general. So that is one of the key determinants for distinguishing these two conditions. Now, I will add parenthetically that these changes that we describe for Pityriasis rosea are certainly not specific for PR. As a matter of fact, you really cannot reliably, histologically distinguish Pityriasis rosea from erythema annulare centrifugum, or at times from subtle expressions of primary eczematous dermatitis, like atopic dermatitis or contact or nummular, in the absence of clinical history. And probably in no class of inflammatory conditions is a correlation with clinical findings so critical than with spongiotic dermatitis in terms of distinguishing the various entities. That being said, we can distinguish something like this, let's say from mycosis fungoides, where you would expect to see more atypical mononuclear cells and pronounced epidermotropism, and as we've been discussing, from gut-taint psoriasis or psoriasis, in which you would see more thinning of the suprapapillary plates, more dilated vessels, more pronounced perikeratosis, and a lot of times neutrophils at the summits of perikeratotic foci, which again are devoid of serum. So hopefully that helps someone. Okay, let's go ahead and move on to slide number 3. Slide number 3 is a bisected shave biopsy. Pull this down a little bit. And we can see we had a shave biopsy from the trunk. And I think even at lower power, one can see a fairly dense infiltrate with kind of a flat bottom here, filling the papillary dermis. Notice the reading are kind of claw-shaped so that the dermal papillae are a little bit expanded here. But what's interesting about this infiltrate, as dense as it is, it's not really producing an interface dermatitis. So while it's band-like, it's not truly a lichenoid interface dermatitis. And indeed, the DE junction, really, you take a look at it, it's fairly crisp. I mean, you could kind of draw a line along the basal layer here and note that there's no obscuration of the DEJ. Well, let's go ahead and zoom in and take a look at the infiltrate. And as we move to higher power, we can see a lot of lymphoid appearing cells. The cells have round to oval nuclei, look a lot like lymphocytes. But hopefully, as you zoomed in, you also began to appreciate the presence of numerous extravasated red blood cells. And if you back out to lower power again, even at lower power, you begin to see, hey, there are a lot of extravasated red blood cells in the dermis as well, too. Let me go and clear my pencil mark. And if we move into higher power, these sections are cut a little thick. Let me back down to this particular specimen as well, too. If we zoom into higher power, and hopefully these will project well. There were also, in addition to the lymphocytes and extravasated red blood cells, histiocytes here that contained dark pigment. And generally when we see dark pigment within histiocytes in the skin biopsies, we're dealing either with hemosiderin or melanin pigment. And of course, we can get special stains to help us. Hemosiderin tends to will stain, highlight with Pearl's iron stain or Prussian blue. And of course, melanin pigment will highlight with Fontana Masson stain. But there are a few clues you can use even without special stains. Hemosiderin pigment tends to be much more variable in size. The granules are chunky, some are large, some are small. Melanin pigment granules tend to be much more uniform. And again, I realize that in this biopsy, it's cut a little thick. It's kind of hard to assess the size of the particulate material. That being said, the old adage, where there's smoke, there's fire. So with a lot of extravasated red blood cells, this pigment's much more likely to be hemosiderin than it is to be melanin pigment. And indeed, this did highlight with a Pearl's iron stain. So what we have here is lichenoid purpura, which is one of the chronic pigmented purpuric dermatitis. Of course, there are a wide variety, a wide clinical spectrum of chronic pigmented purpuras with varying clinical presentations, from lichenoid purpura to Schomburg's purpura. And I think the names are of historical interest, and obviously they can be a source of torture and consternation for dermatologists. Anyway, very characteristic for lichenoid purpura to produce this band-like infiltrate of lymphocytes, extravasated red blood cells, and siderophages, and for the band-like infiltrate to approach the undersurface of the epidermis but not obscure it. So it's one of the few instances in which you're going to see this dense of a band-like infiltrate in the dermis without obscuration of the DEJ. Let me also add parenthetically that with any of these pigmented purpuras, you have to have in the infiltrate either extravasated red blood cells, or if it's a real late lesion, siderophages. If you don't have evidence of either of those two things, extravasated erythrocytes or siderophages, you really can't make the diagnosis of pigmented purpura. Now, another thing that one might consider here in the differential, and I actually thought about it when I first saw this slide, was a halo nevus, because halo nevus tends to produce a very dense infiltrate of lymphocytes that kind of fills the papillary dermis and gives you kind of a flat bottom. But obviously, as we moved into higher power, we didn't see any nest of melanocytes. Sometimes they'll kind of hide out in the infiltrate, and it can be a little bit hard, but usually you have clinical data that will help you out. And if there's any doubt, you can go and get an S100 or a melanase stain. Things like lichenoid purpura, lichenoid photodermatitis, or lichen planish, or other lichenoid differential will obscure the dermal junction, which we don't see here. Okay, let's go ahead and move on to slide number 4. Tilt it here. And in slide number 4, we have a trisected shade biopsy. And, it's kind of a very interesting biopsy on scan. First off, when we're trying to assess location, you might want to think about, oh, maybe this is Acral skin because I've got this real thick stratum corneum. But obviously we know we're not on a volar surface because we've got this hair follicle. The other thing is, if you start looking at the thickness of the stratum corneum, it's really even more thick than the epidermis. The epidermis is kind of thin with effacement of the reedy ridge pattern, and we've got this zone of pallor within the papillary dermis, beneath which we've got a band-like infiltrate. Well, if we move to higher power, we see that indeed there's compact orthokeratosis within the stratum corneum. The epidermis is thin with effacement of the reedy ridge pattern. There's subtle vacuolar change along the DEJ. Not real pronounced, but the DEJ is not real crisp. Again, it kind of looks like a little smudgy. And we've got this greatly expanded papillary dermis here. You can see papillary dermis is thicker than normal, and in this case, it's expanded by subtle sclerosis. There are some dilated vessels, and then beneath the thickened papillary dermis, we have this band-like infiltrate of lymphocytes. And of course, these findings are absolutely classic for lichen sclerosis. We'll back out because I think people talk about the red, white, and blue sign on scan for lichen sclerosis. So the red being the compact ortho and the epidermis, the white being the sclerotic papillary dermis, and then the blue being the band-like infiltrate of lymphocytes. And this just very nicely demonstrates that finding. You could consider the possibility of other superficial sclerosing dermatitides, like chronic radiation dermatitis. But as Dr. Martin pointed out in the session a few weeks ago, with chronic radiation dermatitis, one, you always get an altered dermis. So it's going to be basophilic or elastotic, usually due to a combination of sun damage and the radiation itself. Two, you tend to get very ectatic, widely dilated vessels within the papillary dermis in radiation dermatitis, which we don't see here. Three, you tend to get the radiation fibroblast, plump stellate fibroblast within the papillary dermis, which we don't have here. And lastly, you tend to get adnexal destruction with radiation. We've got an eccrine coil here, but a lot of times you have no adnexy within the dermis in radiation dermatitis. Morphia, superficial morphia, you could think about that, but typically morphia is a deeper process. And even in superficial variants of morphia, you don't get the band-like infiltrate of lymphocytes along the DEJ. That being said, there's considerable histologic overlap, and possibly even pathogenesis involved in the two conditions. And occasionally you'll see a biopsy from a patient with morphia, where you've got classic morphia down deep and changes that look like LS sometimes. So maybe they're more closely related than we think. Okay, we'll go ahead and move on to 5 and 6. And I kind of wanted to discuss these two together. Sometimes in these sessions, you know, we're going to discuss common things because as you're going out into dermatology and looking at your own slides, you're gonna need to be familiar with the histologic findings of common things. And I think a lot of times when we do Dermpath conferences, we kind of drill down on the esoterics. So I think it's a good idea sometimes to go back and cover common things. We have a bisected punch biopsy here. Obviously, this is from a volar surface, very compact cornified layer here, and really no follicular units, have a few eccrine coils in the dermis. And you know, even at scanning magnification, you begin to see a lot of pigments. Oops, I got kicked out here, but let me go ahead and reload my screen here. Path Presenter's been doing this a lot. So, go stop my share. Okay. Okay. Sorry about the delay there. So we'll go ahead, let's see, we were on slide 5. And in slide 5, we have a punch biopsy, again, from an acral surface. And as I was pointing out, even at scan, you begin to see a lot of melanin pigment within the papillary dermis. And you can begin to see as you move down to higher power that there's some pigment present within the epidermis. And there actually were nested aggregates of melanocytes along the DEJ. So we've got a junctional melanocytic proliferation. This melanocytic proliferation is largely nested. The nests are a little variable in size and shape, but in most areas, nests tend to predominate over solitary units. The solitary units of melanocytes that are present are located along the edges and tips of breeding. And you know, the melanocytes are a little bit difficult to discern because of all the pigment, but if you take a look at their nuclei, the nuclei of the melanocytes are about the same size as those of the adjacent keratinocytes. So we don't have a whole lot of atypia here. This lesion does extend to the edge of the biopsy specimen, so we can't really assess all architectural features or really comment on size, although you get the sense that the punch largely encompassed most of the lesion. So we've probably got a small melanocytic lesion here. We've got a lot of pigmentary incontinence within the underlying dermis, but we've really got no confluence of melanocytes along the DEJ, and there's not a appreciable upward scatter. There is kind of just a mild inflammatory infiltrate in the dermis. And if you look at the stratum corneum, you know, you begin to see that we've got columns of melanin pigment within the stratum corneum, kind of across the biopsy specimen. And taken together, these findings are most suggestive of an acral junctional nevus. Now, I would encourage you, when you do biopsy an acral nevus, palm or sole finger, always make sure you let the dermatopathologist know how big the lesion is. Because I think a point Raj made, Dr. Y, at the board review this past weekend was that a lot of times when we biopsy lesions on volar skin, we think we're getting more than we do. So most people, most dermatopathologists really want to know about the size of the lesion and what your clinical index of concern was. And the reason it's so important on these acral biopsies of volar skin is that there's a lot of histologic overlap between melanoma and nevi on volar surfaces. Now, if I begin to see melanocytic nuclei that are large, and particularly if they're hyperchromatic and surrounded by a halo, if the patient's a little older, if I begin to see inflammation, then I begin to get a little more worried, especially if the lesion's recent onset and large, I'm more likely to get more levels and or stains to try and assess architectural features. The other reason I wanted to show the slide was to comment on the fact that a lot of times junctional nevi in a variety of locations will actually begin life as simple lentigos. So initially, what you'll see is elongation of the rete, and then a proliferation of melanocytes arranged as solitary units along the edges and tips of rete. And then over time, some of these will start collecting together, forming small nests at the DEJ. Now, not all simple lentigos will progress to junctional nevi, but a fair number of them do. And occasionally we jokingly say that a lesion looks like a gentigo. So it's largely solitary melanocytes, but maybe you begin to see two melanocytes kind of grouping together and three kind of make a nest. So there is a transition that occurs in a lot of instances from simple lentigo, which is a melanocytic proliferation, to junctional nevus. Now, this is in contrast to the next case, case 6. And in case 6, obviously, this is a punch biopsy. This was actually from the neck, sun damaged skin. And at scan, you can see that we've got a fairly sharply circumscribed lesion here, not all that broad. And there's kind of basket weave hyperkeratosis and a little bit of papillomatosis and acanthosis. And, like the situation that I was talking about with simple lentigo, we've got elongated rete here, and there's hyperpigmentation of the keratinocytes. But as we zoom in, we can see that this is solely a keratinocytic proliferation. We don't have an increased number of melanocytes along the DEJ. There are melanocytes, for sure, in the epidermis. Here's one. You can identify them along the DEJ, but they're normal in number. And if we look over at the edge here, we see the more subtle changes. Again, the rete are kind of elongated. Get my pencil here. And the basilar keratinocytes are slightly hyperpigmented, but there's no increased number of melanocytes. And what we have over at the side is a solar lentigo, and it's kind of transitioning into this macular and early reticulated seborrheic keratosis. And seborrheic keratosis, solar lentiginous, these are epidermal lesions, not associated with an increased number of melanocytes. Solar lentiginous, of course, occur on sun-damaged skin. But much as simple lentiginous can give rise to junctional nevi, solar lentiginous can give rise to reticulated seborrheic keratosis. So remember, people use the term lentigo rather loosely. You always want to state, especially when you're looking at slides, whether you think something's a solar lentigo or a simple lentigo. And again, solar lentigo, elongated rete, sun-damaged skin, no increased number of melanocytes. You get elongation of the rete with pigmentation in basilar keratinocytes. Simple lentigo, again, epidermal hyperplasia, but there you do get an increased number of melanocytes. So melanocyte, one's keratinocytic lesion, one's melanocytic lesion. Okay, let's go ahead and move on to slide 7. And what we're going to do with slides 7, 8, 9, and 10 is look at a group of follicular proliferations that are actually very similar, as I'm sure you know from looking at the slides. Small biopsy here, slide 7. Even at scan, you can see kind of this cystic invagination of the epidermis. And the cystic invagination is contiguous with the surface epidermis, and it really resembles a dilated follicular infundibulum. Of course, infundibular epithelium keratinizes in a very similar fashion to the surface epidermis, with interposition of a granular layer and formation of this loose shred of wheat basket weave keratin. And then emanating from the wall of this dilated cystic structure, you can see these interconnected finger-like projections, which radiate out or extend out in kind of a radial fashion here. And there's no real evidence of any degree of follicular differentiation here. We have an adjacent vellus hair follicle here and here, but these particular buds are not showing any evidence of follicular differentiation. And what we have here, of course, is a dilated pore of Weiner. Now, if you looked at slide 8, first blush looks very, very similar. Here we have a punch biopsy. This is certainly from sun-damaged skin of the face. And again, we have this cystic invagination of the epidermis, looks like a kind of a widely dilated follicular infundibulum, showing infundibular type keratinization with a granular layer and basket weave orthokeratosis. And once again, radiating from the wall of this structure, we have these epithelial projections. But here, these are kind of thick acanthotic fingers. And this is a pilar sheath acanthoma, which is really kind of a robust or a gravid dilated pore of Weiner. Some people describe it as a dilated pore of Weiner on steroids. And this is derived or showing differentiation towards kind of outer root sheath epithelium. And you know, in a pilar sheath acanthoma, unlike in a dilated pore, it's not unusual to see a few little horn cysts, and sometimes you can even see remnants of the sebaceous duct, remembering that the sebaceous duct does enter into the hair follicle, the junction between the infundibulum and the isthmus. But if you see kind of a really robust dilated pore, think about the diagnosis of a pilar sheath acanthoma. The two look similar. One has thin radiating fingers, one has more bulbous aggregates, but in neither of these lesions do we see real well-defined secondary hair follicles. I mean, there's no hair shafts here, there's no inner root sheath, there's no bulb. So that's what distinguishes these two entities from the entity which we showed in slide 9. And I think we showed one of these in an earlier happy hour. And what we have in slide 9, again, is a punch biopsy. Then this again is from the face. And again, we have this cystic invagination of the epidermis, which resembles a very widely dilated follicular infundibulum. But if you look at the epithelial structures radiating from this wall, and these are very well-developed secondary hair follicles. They've got a fibrous sheath around them. You can see in many of them both the development of an inner root sheath with trichohyalin granules and outer root sheath. Some of these actually have little bulbs or inferior portions with these papillary mesenchymal bodies. And frequently, as I'm sure you know, in a trichofolliculoma, some of these can even form hair shafts, and you can see you have a hair shaft here. So what distinguishes trichofolliculoma from dilated pore of Weiner and from pilar sheath acanthoma is clearly well-developed secondary follicles. And again, look for inner root sheath, outer root sheath, inferior portion. So this is a trichofolliculoma. Most people have no problem with this particular tumor. It's so distinct. And I threw in slide 10. It's a little different looking histologically, but the nomenclature causes some confusion. So what we have here is a punch biopsy. Again, this is from the face. You can see a lot of vellus follicular units and some ciliary elastosis. And here we've really got as much of a mesenchymal proliferation as an epithelial proliferation. This has a very benign silhouette. I mean, it's very sharply circumscribed and has kind of its own stroma that's separating from the surrounding dermis. So we've got kind of this orb, if you will, of fibromucinous stroma. I'm going to try and zoom in a little. It's not wanting me to zoom in, so I'm going to go ahead and reload the slide so I can drive it. And let's go and look at the stroma. And sure enough, we can see we've got in the stroma, there's kind of plump stellate fibroblast and a lot of vessels, really more fibrous than fibromucinous, but also embedded within this stroma are these epithelial structures that, again, are kind of primitive. We don't see inner sheath. We don't see the degree of differentiation that we saw with the Trichofolliculoma. And it's the combination of this big orb of fibrous tissue with these kind of primitive follicular structures, which defines a fibrofolliculoma. So I threw it in because it sounds kind of like Trichofolliculoma. Usually if they show one or the other, they're going to put the other in the differential. They show you a fibrofolliculoma, they'll put Trichofolliculoma in the differential. They show you a Trichofolliculoma, they'll put Fibrofolliculoma in the differential just because of the similarity there. But remember, a fibrofolliculoma, it's easy to remember. It's got a prominent mesenchymal component, a big orb of fibromucinous stroma, hence the term fibro, and it's got these primitive follicular structures in it, hence the term follicular. So fibrofolliculoma, and remember, remember the association with Birt-Hogg-Dubé syndrome, which also can, the patients can also get, trichodiscomas, which are probably the same tumors of fibrofolliculoma, and acral cordons and perifollicular fibromas as well. Okay, let's go ahead and move on to slide 11. And we're going to close out here with a couple of neutrophilic blistering conditions, which bear some similarity to one another. So we have a bisected shape biopsy. And as we move to slightly higher power, you can see within the dermis, and this is probably from trunk or proximal extremity, there's a little bit of ciliary elastosis here. But anyway, we notice there's a superficial and deep perivascular infiltrate. And then moving to higher power, you begin to note a fairly broad subepidermal blister here. Here the epidermis is kind of stripped off, probably at the time of cutting. And this is a fairly cell-rich subepidermal blistering disorder. Remember, when we do identify in Dermpath a subepidermal vesicle, the first question we want to ask is it cell-rich or is it cell-poor? And if it's cell-rich, we need to go down and take a look at the cell type. And if we look in the blister cavity, we can, of course, see fibrin. And there's kind of a mixed cell infiltrate. There are a few scattered eosinophils, but clearly many more neutrophils here than eosinophils. The eosinophils may be late arrivers to the party. Notice that there's no evidence of excoriation here. We've got this large subepidermal blister, many neutrophils, a few eosinophils, and then down in the dermis, we have a perivascular infiltrate here of lymphocytes and a few scattered eosinophils. And so right away, you begin to think about the possibility of an immunobullous disorder. And when we think of immunobullous disorders dominated by neutrophils, the two things that come to mind right away are dermatitis herpetiformis and linear IgA bullous dermatosis. but also in the differential, bullous LE, because that can give you neutrophils as well. And you can even think about epidermolysis bullosa acquisitum, which can present with a wide variety of histologic patterns, and possibly even, I'm drawing a blank here, possibly even neutrophil predominant BP, something like BP 200. And so we have this picture, and I could say of those entities here, I would be thinking a little less about DH. We don't have any papillary dermal microabscesses, and DH tends to be so pruritic that a lot of times, the patients will come in, the clinician will do 2 biopsies, will do a perilesional for immunofluorescence, and a lot of times they have a hard time finding even an intact lesion to biopsy because the patient has just excoriated them. So I'm not saying this couldn't be DH, but the fact that we've got this broad subepidermal blister with no papillary dermal microabscesses and no evidence of an excoriation, at least in my experience, would make it a little less likely. Clearly, this could be linear IgA bullous dermatosis. This could be neutrophil-rich BP. The presence of eosinophils here would strongly militate against the possibility of bullous LA. And this could be EBA. So, the bottom line is when I see this, 9 times out of 10, the clinician's done a corresponding immunofluorescence and biopsy for DIA. If not, I'll get them on the phone and see if I can kind of ferret out what he was thinking clinically and what the patient looked like. In this particular biopsy, the DIF was positive for linear IgA, and the patient had received vancomycin. So this was a beautiful example here of linear IgA bullous dermatosis. So again, the blisters tend to be a little bit broader without the papillary dermal microabscesses. And in my experience, this superficial and mid-dermal or deep perivascular infiltrate that contains lymphocytes and eosinophils, it is seen not infrequently in linear IgA bullous dermatosis. Obviously, you're going to want to confirm with IAP, but in my experience, this has been a feature that at least makes me more strongly consider that item in the differential. And let's go ahead and close out with slide 12. Slide 12 is a punch biopsy. This was from the trunk. And we can see we've got a superficial perivascular infiltrate. Obviously, the epidermis here is somewhat hyperplastic. There's a little bit of edema here. You can see even at scan involving the papillary dermis. The dermal papillae are somewhat widened. And if we look in the dermal papillae here, lo and behold, we see, in addition to lymphocytes, scattered neutrophils, and even a few eosinophils. And this is the characteristic feature that one sees in Dermatitis herpetiformis. This patient did have linear IgA, granular IgA deposits in the dermal papillae. I have seen stuffing of the dermal papillae like this rarely in the setting of connective tissue disease, like bullous LE. Usually you'll see corresponding macular change along with EEJ. And again, the presence of eosinophils, which we've got here, would be very, very unusual for connective tissue disease, not an infrequent finding in Dermatitis herpetiformis. So, certainly appreciate everybody tuning in today. And again, if you have any questions at all, any suggestions for future seminars, please email us at education@sagisdx.com. Feel free to email me personally or call or text on my cell phone. Thank you, and we'll see you guys next week.